A quick word from our sponsor, Freed. In today's healthcare system, clinicians are overworked, underpaid, and burdened with tons of administrative tasks. And add this to actually taking care of our patients, it's not surprising that clinician burnout and shortages are at an all-time high. Over the last year, Freed has helped over 9,000 clinicians save hours in their day with their AI scribe that listens, transcribes, and writes medical documentation for clinicians. And yes, it is HIPAA compliant. Freed can be used across all specialties in and out of the office and can actually record up to 2 hours of notes. Documentation no longer has to feel like a big lift. Give it a try and see if the AI scribe fits well into your workflow. CoreIM listeners can use the code CORE50 to get $50 off their first month of Freed. Again, use the code CORE50 to get $50 off your first month of Freed.
This is a really confusing condition. So if you're confused, it's not because there's something wrong with your diagnostic abilities, it's that it's a very confusing condition.
That's Dr. Emily Lau, a cardiologist at Mass General. Welcome to the CoreIM 5 Pearls podcast, bringing you high-yield, evidence-based pearls. This is Dr. Shreya Trivedi.
And Dr. Rati Vani, an internal medicine resident at Beth Israel Deaconess Medical Center. And today, we will be focusing on heart failure with preserved ejection fraction, aka HFpEF.
And hopefully we will make this topic a little bit less confusing with what we do and what we don't know about HFpEF. So let's get started with the pearls that we'll be covering today. Be sure to test yourself by pausing after each of the 5 questions. Remember, the more you test yourself, the deeper your learning gains.
Pearl 1. What is HFpEF?
What causes HFpEF and what are the biggest risk factors?
Pearl 2. Echo findings and diastolic dysfunction.
Does diastolic dysfunction imply HFpEF? And what are the typical echo findings in patients with HFpEF?
Pearl 3. BNP.
What are BNP levels influenced by, and is a BNP level helpful in HFpEF?
Pearl 4. Advanced testing.
What scoring systems can be helpful in ruling in HFpEF, and what are other imaging or testing that we can do when the diagnosis of HFpEF is not as clear?
Pearl 5. Treatments for HFpEF.
What's the first and second line treatment for HFpEF? All right, Radhi, I was so surprised when we started this episode. A lot of my cardiology friends said, HFpEF, you're doing that topic? That's probably one of the hardest topics to cover. And I was like, really? HFpEF, the thing that's in everybody's one-liners?
I know. So it turns out the HFpEF is such a heterogeneous disease, and we actually just don't know a lot about it. So a lot of preparing for this episode has actually been unlearning what I had associated with HFpEF before.
Needless to say, we were ready for this challenge to clarify the murkiness around HFpEF, and we're so excited to share what we learned. And as Rati just mentioned, a lot of what we unlearned.
So to start off, in the most simple terms, HFpEF is the clinical syndrome of heart failure with an EF of 50% or higher.
Heart failure in and of itself is a syndrome, and in cardiology, we have few syndromes. So in its broadest sense, heart failure with preserved ejection fraction is defined as a clinical syndrome, most commonly which presents with dyspnea either at rest or with exertion, that is due to a rise, typically in left ventricular filling pressures, at rest or with exercise.
That's Dr. Ravi Patel, a cardiologist and director of the HFpEF program at Northwestern. And these definitions make HFpEF seem so straightforward, right? But now that we know more, I want to put a huge highlighter, like med school level, double underline the word syndrome with HFpEF syndrome.
I do think in general, when we're talking about HFpEF, we're not talking about conditions with known etiologies. We're really talking about this kind of umbrella term, poorly understood systemic disorder condition. And this is why this is one of the hot topics in the cardiovascular community today, because we simply don't understand this condition at all. We don't yet have a consensus on how to diagnose this condition. It's probably multiple conditions all under an umbrella term of HFpEF. And understanding and sort of respecting the ambiguity, I think, is actually an important principle.
And to clarify why this HFpEF syndrome is poorly understood and a systemic disorder, we have to first understand how HFpEF even develops. Dr. Jen Ho, an advanced heart failure and transplant cardiologist at BIDMC, did a great job explaining so succinctly just that.
So the pathogenesis of HFpEF is really complex. I'm not sure anybody fully understands what happens. We used to think of HFpEF really as a disease related to hypertension and hypertensive LV remodeling that leads to LV stiffness. And I think this has really shifted more recently to this idea that it happens in multi-morbid patients with central contributions from obesity and cardiometabolic disease. We think that those predisposing factors probably incite systemic inflammation that then leads to endothelial dysfunction and altered myocardial energetics and abnormalities in skeletal muscle. And so it's a lot more complicated, I think, than we initially appreciated.
Okay, so on to unlearning point number 1. HFpEF is not that classic high blood pressure causing stiff ventricles that we may have learned about back in the day. HFpEF is so much more. And what really stood out to me is that it's not the heart as the initial culprit in the classic garden variety HFpEF.
Whereas in garden variety HFpEF, you're talking about a culmination of one's cardiometabolic risk profile that then seems to activate inflammation, that then leads to all these downstream sequelae that then kind of lead to structural changes and functional changes of the heart that can then contribute to the syndrome of signs and symptoms of heart failure and preserved ejection fraction.
As we think of HFpEF as a syndrome from the outside in that's affecting the heart, as opposed to HFrEF, which is an intrinsic myocardial process that then exhibits negative effects to all other organ systems.
I love that comparison of HFpEF to HFrEF.
And also for those of you that are not in the know, HFrEF is what the cool kids say as heart failure with reduced ejection fraction.
Thank you so much for clarifying, Shreya. I hope it's mostly the cool kids listening to us, but we can pretty much think of HFrEF as a central cardiac disorder where after the EF takes a hit, there are all of these downstream effects on other organ systems. But with HFpEF, it starts as a systemic disorder with all of these outside cardiometabolic risk factors like obesity, prediabetes, hypertension, and all of those kind of come together and lead to this pathogenesis that nobody fully understands, but has something to do with inflammation, and that then affects the heart.
Yeah, now that I think about it, all the classic one-liners for most of our patients is like 72-year-old woman with hypertension, hyperlipidemia, type 2 diabetes, and HFpEF presents with X, Y, and Z.
So your one-liner there actually highlights another big risk factor, an older person.
HFpEF is outstripping HFrEF as the most common type of heart failure. And as we get older, our immune systems change. There is more adverse inflammation that may occur, and there is an accrual of comorbidities as well that can ultimately lead more likely to HFpEF than HFrEF.
Wow, so interesting to think that people, as they get older, their immune systems change and how we may be prone to more inflammation with just natural aging, and that contributes to this syndrome.
I know. And there's actually also one other demographic risk factor that I wanted to bring up because it was actually one of the reasons why I chose this topic.
Oh yeah? Which one is that, Rathi?
So HFpEF affects a higher proportion of women compared to men. Dr. Lau has a clinical interest in this, so I was really excited to pick her brain and see what she's thinking about this trend.
We're increasingly also beginning to recognize that there are other female-specific risk factors like history of preeclampsia, which may also be related to HFpEF. And so it really underscores this idea that HFpEF is really a systemic condition.
Oh man, I'm just trying to wrap my head around how certain aspects of pregnancy, like hypertensive disorders, like preeclampsia, and those things might make someone different in terms of inflammation and what that means later with these increasing proportions of women developing HFpEF.
Yeah, so if we think back, rewind your brain back to med school, think about the pathogenesis of preeclampsia. we can remember it involves systemic inflammation and endothelial dysfunction. So when you see it like that, it kind of makes sense that we have this connection with HFpEF. And the caveat we should say is there is still a lot left to be uncovered about these female-specific risk factors.
Yeah, I guess caveats aside, it seems like inflammation just is all over and is rearing its head again. And I think, again, it really reiterates to me the biggest takeaway is to change my one-liners from just HFpEF to say HFpEF syndrome to really do it justice.
So to summarize what I've learned about HFpEF syndrome...
See what you did there.
Thank you. It's the systemic disorder that is the culmination of a patient's cardiometabolic risk factors and even things we don't fully understand related to pregnancy. All of that activates inflammation and endothelial dysfunction, which then alters the structure of the heart. And then these structural changes in the heart lead to a rise in LV pressure either at rest or with exercise.
And then before we close out this pearl on what HFpEF is, we should caveat that there's tons of HFpEF, quote unquote, masqueraders. And it's not all the classic garden variety HFpEF that we've been talking about, right? The typical patients who have hypertension, obesity, diabetes.
Yeah, and HFpEF has such a broad definition, it's hard not to label everyone with it because almost everybody that comes into the hospital has a little bit of dyspnea. Most of them have an EF greater than 50%.
Now, something that comes up a lot in terms of diagnostic workup is that there are things that can look like HFpEF that we call HFpEF masqueraders that can cause heart failure with normal ejection fraction. And so it's really important to try to identify and differentiate HFpEF masqueraders from what I call garden variety HFpEF because the management is often really different.
Cirrhosis, nephrotic syndrome are things that, you'd be surprised, but sometimes come into my clinic and are billed as potentially HFpEF.
It's kind of crazy to actually think through the list of things that can cause a little dyspnea. I wouldn't even know where to begin.
Yeah, it is. I think maybe one branch point is to separate out the cardiac HFpEF masqueraders versus the non-cardiac HFpEF masqueraders. And so typical cardiac masqueraders include things like amyloidosis, sarcoidosis, valvular disease. And then non-cardiac masqueraders are the things that Dr. Patel just mentioned, right? Nephrotic syndrome, cirrhosis, anemia, of course, anything with the lungs.
Our reviewers actually pointed out how we need more on HFpEF masqueraders, and we honestly just weren't able to cover it all in this episode. So just look out for a bonus episode on HFpEF masqueraders. So since the syndrome is so heterogeneous, let's dig into the objective data that can make us more confident when we're trying to figure out, does someone have HFpEF? Do they not have HFpEF?
Yes. Let's get into all things echoes.
Finally.
I bet that makes your cardiology heart very happy, Rathi.
It sure does. So with the echo, we can first look at diastole. And diastole is the ability of the heart to relax, to fill with blood.
And then the term that we always hear with HFpEF is diastolic dysfunction. But I think the money question is, does diastolic dysfunction mean slam dunk HFpEF?
I always go back to the classic physiologic definition of heart failure, which is the inability of the heart to meet the metabolic demands of the body or to do so at the expense of elevated filling pressures. And so it's a clinical syndrome at the heart of it. So if you just have an imaging finding of diastolic dysfunction, but the person doesn't have any symptoms of heart failure, can exercise, run 5 miles, that is not HFpEF by definition, right? You have to have the clinical syndrome.
Okay. Unlearning point number 2. I think I have to repeat this to myself a bunch. HFpEF and diastolic dysfunction are not synonymous terms. Diastolic dysfunction is an abnormality with relaxation or filling that is separate from HFpEF syndrome, which requires clinical symptoms.
Now, invariably, diastolic dysfunction is an important component. We know patients with heart failure with preserved ejection fraction have LV stiffness as a big problem that really makes them exercise intolerant. And so this is a really complex issue. I would look at them as slightly overlapping Venn diagrams. There are people that have both, but having diastolic dysfunction does not mean you have HFpEF automatically in the absence of the clinical syndrome.
This brings up unlearning point number 3. Rathi, I used to look at echoes, and if I did not see diastolic dysfunction somewhere in the impression, I kind of ruled out HFpEF for their symptoms that they were having, but that was not the right way to think about it.
So you can have HFpEF without diastolic dysfunction, and it is quite common. We see it more and more. diastology and the assessment of diastology is one aspect of understanding if an individual has HFpEF, but it's not the whole story. What we've come to realize is that while diastolic dysfunction is prevalent in many patients with HFpEF, there are also many patients who do not have that same delayed relaxation of the heart, that true diastolic dysfunction as you would measure it on an echocardiogram, but still have a syndrome of heart failure, which is a rise in left ventricular filling pressures at rest or with exercise.
That's so interesting. I actually started reading into that, and I was surprised to learn that up to 1/3 of patients with HFpEF don't have diastolic dysfunction on their resting echocardiograms.
Yeah, and this may be getting too much into the weeds, but if you are someone who doesn't just like to look at the impressions, there's actually 4 specific things to look at on an echo to determine diastolic dysfunction. We'll link more in the show notes, of course, but just like big picture, what are those 4 things? 1, LA enlargement or the LA volume index. 2, the E to E prime being greater than 12 to 14, which just means how hard is that left side of the heart working to pump blood. 3, looking at tissue Doppler velocities, particularly the septal and lateral E prime velocity. And then lastly, the TR velocity. And if 3 or more of those are abnormal on the echo, that's diastolic dysfunction. If 2 are abnormal, it's quote unquote indeterminate.
The other point to keep in mind with echo is it can be helpful when it's abnormal. However, some people with HFpEF can actually have normal echoes as well. So that's what makes it really, really tricky.
Wait. Okay, so we just went over that patients with HFpEF do not necessarily have diastolic dysfunction, but now you're telling me that some patients with HFpEF have no abnormal findings on echo?
That's exactly what we mean. And this blew my mind too.
There was a trial called Paragon HF, which looked at ARNI versus ARB in patients with HFpEF. And the echocardiographic sub-study looked at a bunch of patients who were enrolled with known HFpEF, and up to 1/3 had normal echoes, meaning they didn't have evidence of left atrial enlargement or left ventricular hypertrophy. And so you can see that, again, echo is not a gold standard diagnostic test for HFpEF. Some people, for all intents and purposes, can have normal looking echoes and still have the clinical syndrome of HFpEF. So that's, I think, another challenge in this field.
Oh, yeah. Another wrench to throw into the diagnostic challenge. And I really like cardiology because I really like when things make sense. So I loved how Dr. Patel explained how particularly patients with obesity might have normal echoes.
Essentially, there's a syndrome that we are beginning to see where, especially in obese patients, where patients' hearts are just essentially mismatched in terms of size. So their LV size is just not big enough to handle the amount of circulating blood volume that they have. As a result, they might not have elevations in filling pressures at rest, but when they exercise and more circulating blood volume is required, they will have elevations in their wedge pressure and symptoms of dyspnea.
So another way to frame this is that the heart can't supply the metabolic demands of the body in obesity. And this can lead to high output heart failure, which can actually be considered a subset of HFpEF.
Oh, yeah. So I guess you're saying that, in patients who have obesity, there's more cells and that's creating more demand, and that can lead to the classic symptoms of heart failure.
That's a great way to put it. So often patients with obesity will have normal echoes at rest, but then it's really when they're getting up and on exertion that their LV can't compensate for these higher circulating volumes, and that leads to the higher pressures we see.
I used to think that someone could not have heart failure unless they had a large atrium and stiff ventricles, meaning their E to E prime ratio was greater than 12 to 14. But yeah, I realized that was not the case.
I'm totally with you there, Shreya. I'm used to being on heart failure rounds and looking at echoes and pointing out how dilated the atria are. So let's take a minute to talk a little bit more about the left atrium.
We assume that diastolic dysfunction is also resulting in certain aspects we see on an echocardiogram, like left atrial enlargement. Left atrial enlargement in and of itself does not measure anything with regard to diastology, but it's felt to be a surrogate for chronically elevated left ventricular filling pressures. And the same goes for pulmonary artery or right ventricular systolic pressures on echo, which we use as a surrogate for diastolic dysfunction.
It looks like all of these echo findings tie together, and none of them in particular give us a clear picture on their own. So patients with HFpEF, they can have a clear combination of all of these findings, but they could also have none of these findings at all.
Yeah, it is a hard topic. But let's try to summarize what we're taking away. So we learned that having diastolic dysfunction doesn't label someone as HFpEF. And on the flip side, we also learned that not having diastolic dysfunction on the echo doesn't not mean HFpEF. A patient needs to have the clinical syndrome of volume overload and elevated left filling pressures at rest or with exercise, which we talked about in obesity. And they can have completely normal echoes, meaning normal LA sizes and all those E prime velocities. So that was all echoes. What about brain natriuretic peptides, BNPs? Can that help us out with something a bit more objective when it comes to HFpEF?
BNP is a very unique hormone. It's obviously one that's secreted by the heart, and its secretion is stimulated by wall stress. Okay, so wall stress of the LV, wall stress of the LA, and potentially the RV will contribute to elevation in BNP. So if one is potentially congested, BNP will go up as a result of wall stress.
So that all makes sense in theory. The wall stress means that the BNP should be elevated, and technically, this should be able to help us out with the diagnosis of HFpEF.
There are various different reasons why you can have an elevated natriuretic peptide level. The most typical reason is with cardiac stretch, and so that's what makes it such a good marker of heart failure. So we know that, of course, in patients presenting with dyspnea and suspected heart failure, natriuretic peptides are sort of the central test that we send to try to verify whether or not they have heart failure. I think certainly in the setting of chronic kidney disease, in the setting of atrial fibrillation, your natriuretic peptide levels can often be more elevated than what we would typically see in just volume overload states. Women typically have higher natriuretic peptide levels compared with men in general. So I think that's so fascinating. We don't really know why. And then I guess the flip side, similar to echo, a normal natriuretic peptide level, unfortunately, is not awesome at ruling out HFpEF.
Bummer. It sounds like BNP by itself is another test that can be helpful, but it's just one more piece of the puzzle. Bradley, can you help us kind of make it all make sense a little bit? Why would a BNP be normal in some patients with HFpEF?
So what I learned from talking to our experts is that NT-proBNP is influenced by all sorts of factors like age, obesity, or as Dr. Ho mentioned, atrial fibrillation and kidney disease.
So it sounds like most of these confounders are related to the garden variety patient who has HFpEF, all these, especially being with the metabolic syndrome and all. So I can see how things kind of add up to be a bit tricky.
Yeah, and it gets even trickier because one surprising confounder I learned is our patients with hypertension over time, they develop LV hypertrophy, and that actually ends up lowering the BNP.
Hypertrophy of the LV will actually create less wall stress. So a condition that is very common in HFpEF can actually paradoxically result in lower BNP. So the stimulus for BNP going up, which is increased wall stress, goes down in the setting of LVH. So that's one reason why it's not as helpful, or it might not rise as much. The second is the clearance of BNP, which we think is due to adipose tissue. We think adipose tissue clears natriuretic peptides out of the circulation. So in patients who are obese, they may have lower BNP because that BNP is being cleared more quickly.
This is such interesting physiology. When there's left ventricular hypertrophy, that decreases wall stress, and then less BNP might get leaked out, and adipose tissue on top of that clears the BNP.
And then I also learned a new term that was pretty interesting, BNP deficiency.
There's thought that potentially there are patients who are BNP deficient. BNP is a marker, but as a hormone in its function, it's a B-type natriuretic peptide. It results in natriuresis. It's a vasodilatory hormone that is a beneficial hormone. We've studied natriuretic peptide analogs as therapies for heart failure. And so there's a thought that there are some patients who don't secrete enough BNP and their BNP is low, and that might actually drive some of their heart failure, that they don't have this beneficial hormone. And so that's why we don't see it in the circulation.
That's such a new way of thinking about BNP as a helpful hormone in heart failure. I'm just so used to seeing an elevated BNP and thinking, oh no, but maybe I should actually be more concerned when I'm looking at a patient and they're clearly volume overloaded to me. But then I turn and look at the computer and I see that the BNP is like really surprisingly low.
We know there are patients who have natriuretic peptide deficiency, we call it. They can often have very low natriuretic peptide levels despite being very volume overloaded. In some studies, we think this is tied to having obesity. Some of it might be related to insulin resistance as well. And we know there are natriuretic peptide gene variants that can often affect your natural levels of natriuretic peptides and cause some variation between individuals, even in healthy states. So all of those reasons are potential etiologies for natriuretic peptide deficiency. And so when you see a normal BNP in someone presenting with true clinical heart failure, they still have true clinical heart failure.
Okay, so to recap, BNPs are normally produced and released when there's increased myocardial wall stress. But the BNP level can be normal in HFpEF, especially when there is left ventricular hypertrophy that's been going on for a while or obesity. The last interesting thought to end with is that there's actually BNP deficiency, which can actually leave some of our patients more susceptible to volume and pressure overload.
Before we get into advanced testing for HFpEF, it might be helpful to recap the big picture of where we are.
I think that HFpEF is a very unique syndrome in cardiology. Again, we don't have one diagnostic test. I am very, very reticent to rule out the diagnosis of HFpEF based off of a single test, whether it be a BNP, an echocardiogram, specifically those two criteria. And I would say that that's one of the things that I've learned a lot is that, you know, there's no one test to rule in, but there should be no one test to rule out either. So if there is a patient that you see in clinic that is complaining of shortness of breath and things don't smell cardiac based off of laboratory testing or echocardiographic testing, just be mindful that there is a possibility that it is still HFpEF that's lurking.
So there's a lot of clinical gestalt and factors you're weighing together when you're thinking about HFpEF. And it just makes me wonder, are there any helpful HFpEF risk calculators that can guide us one way or the other?
I do think the risk scores may be helpful when the diagnosis isn't clear based on your first tier testing. So your first tier testing, I would say, is your clinical exam, your history, natriuretic peptides, and echo. If after that the diagnosis is still not clear, I think potentially getting some sense from these diagnostic scores of risk stratification can be helpful.
We asked Dr. Ho to tell us a little bit more about these risk calculators and how to use them, when to use them, if we should even be using them.
There are two diagnostic scoring algorithms that have been developed in recent years. One is called the H2FpEF score, and the second is called the HFpEF score. The idea of both of these scores is that they incorporate comorbid conditions plus natriuretic peptides plus echo findings to kind of risk stratify people. And if you have a low risk score, you effectively rule out HFpEF. If you have a high risk score, you effectively rule it in. And if you're intermediate, those are the people where we may want to consider pursuing advanced testing. So those are the two scores. I would say that there's some potential for misclassification with these scores. And so we just have to be cautious. For example, the H2FpEF score was developed in the Mayo Clinic where people get referred if there's a question for HFpEF. And so the pretest probability walking in the door of somebody having HFpEF was something like 60% or greater.
Okay, so we have to think carefully about who we invoke these risk calculators on. So I'm curious then, who is it useful for?
But there are people who do walk around with HFpEF who may not be hospitalized frequently, if at all, and this score can be extremely useful for them. So I use it in the outpatient setting a lot among patients who have never been hospitalized and are having dyspnea-related syndromes and have seen pulmonary or seeing me and have not had a diagnosis made. I'll use this as a screening tool to say, well, what's the probability of having HFpEF?
So in some cases, when it's really hard to tease out, is this HFpEF, is it not? And especially if the patient's exam is tough to tell if they're volume overloaded and their symptoms are kind of vague, then it's helpful to reach for some more advanced testing options like right heart cath or cardiac MRIs.
There are cases that are challenging where the diagnosis is still not clear. You're not really sure where the JVP is. It's hard to see. And in that setting, if the diagnosis is still not clear, I do think I sometimes turn to what I call advanced testing, and that can involve invasive hemodynamic testing. So we can do, for example, a right heart catheterization to assure that what we think is the JVP on exam is actually evidence of elevated filling pressures in somebody. And so that might be really helpful to confirm your diagnosis in cases when you're still not sure and the exam maybe is not so clear.
Man, can I just say how validated I feel when cardiology sees one of my patients and they're also like, yeah, that exam's hard. Recommend right heart cath. And I'm like, yes, please. Thank you.
I know exactly how you feel. And
yeah,
especially when you have a patient who only has symptoms with exertion.
So patients often feel fine at rest, but with exercise, they get short of breath. And it's often not diagnostic when all of our diagnostic tests are when the patient is lying down in the left lateral decubitus position that we're going to be able to identify this syndrome. It's a syndrome that is exertional. It's a syndrome that is exercise induced. And so a lot of times we have to bring a patient to the cath lab, put a right heart catheter procedure and get that done, understand what their physiology is when we perturb the system, when we exercise them, to really understand what's going on. And that's not easy to tell in clinic.
Wow, I have never heard of someone exercising during a right heart cath. Dr. Ho did agree that it's a pretty good provocative maneuver, but she did also share some other options in case exercising isn't possible.
The other provocative maneuvers that have been studied in that setting are either passive leg raise. So it turns out that even with passive leg raise and increasing your venous return, sometimes you can sort of provoke an abnormal response. And then the other potential maneuver to consider is volume challenge. So you can give them some IV fluid and sort of see, do they have, again, this like very exorbitant rise in LV filling pressures that indicates LV stiffness, if you will.
Okay, so that's the right heart cath. What about cardiac MRIs? When can that be helpful?
So cardiac MRI or other advanced testing isn't required for a diagnosis of HFpEF, but cardiac MRI can be really helpful to investigate those HFpEF masqueraders we talked about way at the beginning, like amyloidosis.
Okay, so it sounds like cardiac MRIs aren't necessarily going to give us more information about the typical garden variety HFpEF that we've been talking about for most of this episode. It's really going to be more helpful in investigating HFpEF masqueraders, which definitely kind of changes management of things. So to wrap up this Pearl, we talked about risk calculators for HFpEF, which is typically used in more ambiguous cases in the outpatient setting where you're suspicious of possible HFpEF. And then for particularly tricky cases, we can reach for other things like right heart caths, especially when we want to provoke symptoms during exercise. Okay, now that we have unlearned a ton when it comes to the diagnosis of HFpEF, I've lost count of how much I have unlearned. Let's round things out with a bit more on management of HFpEF.
HFpEF is a disease of multimorbidity. And so often it's really hard to completely attribute someone's symptoms to one single cause alone, right? Often we see patients who have obesity plus HFpEF plus COPD plus diabetes and hypertension and maybe some valvular component to this as well. And I think it's really challenging and often impossible to kind of pinpoint your finger as to one etiology that's going to fix all of their symptoms, because often they're presenting with multimorbid conditions. And so really making sure we're treating their hypertension, their coronary disease, we've optimized their diabetes treatment, we're thinking about obesity. So all of those things are really important.
I really appreciate how Dr. Ho talks about treating risk factors as part of the management so explicitly. I know that when I look at notes and under the hashtag HFpEF problem, I rarely see focusing on risk factors for HFpEF.
Yeah, same. I'm glad we went over that. Something else that I think I can change in addition to HFpEF syndrome kind of making sure there's a risk factor point in there. With that being said, let's move on to medications for the true clinical HFpEF. I know when it comes to heart failure with reduced ejection fraction, those seem a bit more straightforward with the GDMT that we have. But I'm curious kind of with HFpEF, what's the treatment that we actually have on deck here?
In terms of a general approach, I would say I typically consider SGLT2 inhibitors broadly in everyone with HFpEF. When there's congestion present, I actually really like potentially considering upfront mineralocorticoid receptor antagonists because they can treat some of the congestion and may minimize your use of the loop diuretic. But if people still have congestion, then of course we're using loop diuretics. And then in the setting of persistent symptoms with blood pressure room, I would consider ARNI.
Okay, so the key players in HFpEF are SGLT2 inhibitors and mineralocorticoid receptor antagonists, aka MRAs. We can also think about ARNIs, especially if blood pressure is an issue, and then we cannot leave out the huge utility that we get from loop diuretics for symptom management.
With all that kind of laid out, let's take a closer look then to the first-line treatment in HFpEF, SGLT2 inhibitors.
There have been 2 pivotal trials that have really put SGLT2 inhibitors on the map as first line for anybody with HFpEF. Those 2 trials were Emperor Preserved and Deliver, and they looked at treatment with either empagliflozin or dapagliflozin.
So these studies showed that empagliflozin decreased the risk of heart failure hospitalization and cardiovascular mortality. We love that. And this is again in patients with HFpEF, as well as a heart failure with mid-range ejection fraction, which has a cutoff of EF greater than 40%. I think the cool kids say HFmEF for that. Arathi, is that correct?
Yeah, as a cool kid myself, I would say HFmEF.
Nice. You're definitely more in the know than most of us.
Thanks, Shreya. And to build off of that, the second line treatments after an SGLT2 inhibitor is added include both an MRA and an ARNI.
Yeah. So with the MRA, we know from the TOPCAT trial that spironolactone is associated with a small reduction in cardiovascular hospitalizations.
Yeah, but spironolactone didn't reduce cardiovascular deaths in HFpEF in that trial.
Okay, that's all good to know. And then what about ARNIs? When are we reaching for that? And what's the story behind why ARNIs kind of made it into the second line?
Angiotensin receptor neprilysin inhibitors, or ARNI. The trial that looked at the use of these agents is called Paragon-HF. The overall trial was neutral, but subgroup analyses showed some potential benefit in people with what they called below normal EF, and interestingly also benefit among women compared with men. So currently, ARNI use deserves a Class 2B indication in the US guidelines, and I would say that we're using them mostly in people who have persistent symptoms on an SGLT2 inhibitor who also have evidence of hypertension, and in particular in people with below normal EF or in this awkward category of heart failure with mid-range EF.
Okay, so ARNIs for heart failure, so sacubitril valsartan or Entresto, didn't reduce heart failure admissions or cardiovascular mortality more than valsartan alone. But the good thing was that the ARNI group did have improvements in symptoms.
I do have to take a moment to point out here, Shreya, that it's really fascinating what Dr. Ho mentioned, that Paragon-HF showed how ARNIs led to a reduction in heart failure hospitalizations and cardiovascular mortality in women, but it didn't do the same thing for men.
Yeah, that is really interesting to say. And again, it's all subgroup analyses, but maybe this is a good point to recap treatment of HFpEF. First and foremost, it goes without saying that we need to address risk factors of HFpEF. We just don't want to throw on medications, right? But then when it comes to meds, our first line treatment in HFpEF is going to be the SGLT2 inhibitor. And then after that, we can either add a mineralocorticoid receptor antagonist if there's congestion, or an ARNI if the patient has a slightly lower EF, or maybe in women, though, again, this is all kind of subgroup analysis and the data is just more for us to consider than like a hard recommendation.
As we keep learning more about HFpEF, there's going to be even more to consider. So, you know how we hear about GLP-1 agonists like all the time now.
All the time. Yeah, definitely.
So it's not really surprising that they have a role here as well.
There's a lot of excitement around an evolving role of GLP-1 receptor agonists. There were some promising data recently published and presented with a trial called STEP-HFpEF. that showed that GLP-1 receptor agonists in patients with HFpEF resulted in a sustained weight loss, but also really remarkable improvements in quality of life and also 6-minute walk distance. We don't have trials powered on outcomes just yet, but I think this will be a quickly evolving landscape.
And like all things in cardiology, there's just so much research, and I'm sure the landscape will evolve rapidly, and we'll have data on GLP-1s when it comes to hospitalizations and mortality and all the things we care about pretty soon.
And on that note, that's a wrap for today's episode.
Please share this with your colleagues or anyone else who you think may find this episode helpful. Please check out our YouTube channel for some behind-the-scenes interview content that didn't make it on air but was still so good.
And a huge thank you to our reviewers, Dr. Greg Katz, Dr. Snehal Bhatt, and Dr. Randy Goldberg. This episode was made in part from the Digital Education Tract at BIDMC. Thank you so much to all the mentors involved in this work.
And thank you to Dr. Patia for the audio editing, as well as to Dr. Michelle Lowe for the accompanying graphic. Opinions expressed are our own and do not represent the opinions of any affiliate institutions.
This is the story of the one. As a maintenance engineer, he hears things differently. To the untrained ear, everything on his shop floor might sound fine, but he can hear gears grinding or a belt slipping. So he steps in to fix the problem at hand before it gets out of hand. And he knows Grainger's got the right product he needs to get the job done, which is music to his ears. Call, click Grainger.com, or just stop by. Grainger, for the ones who get it done.